Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This marks the second episode of our ongoing series, a program on JAK inhibitors for atopic dermatitis, hosted by expert dermatologist Dr. Christopher Bunick, Associate Professor of Dermatology at Yale University in New Haven, Connecticut. Dr. Bunick, as well as various expert guests, will be discussing the evolving role of JAK inhibitor therapies in the management of atopic dermatitis over the next several months. Thank you again for joining us for our second episode, JAK Inhibitors in Action, Effectiveness in Atopic Dermatitis, featuring Dr. James Song, Co-Chief Medical Officer and Director of Clinical Research at Frontier Dermatology in Seattle, Washington.
Hi, this is Christopher Bunick, and welcome back to the program on JAK inhibitors for atopic dermatitis. This is episode 2, titled JAK Inhibitors in Action, Effectiveness in Atopic Dermatitis. And my guest today is Dr. James Song, and we're going to dive in deep into understanding the role of JAK inhibitors in treating atopic dermatitis, in particular focusing on efficacy today, as well as we'll touch on real-world application and safety, which is the larger mission of this entire podcast series, is really to understand this role of JAK inhibitors in AD from multiple different lenses. So Dr. Song, thank you so much for joining us today for this podcast.
Great to be here, Chris. I'm looking forward to our conversation today.
Excellent. So I thought we could start out for our listeners, which is kind of an overview of JAK inhibitors. Can you provide us a little bit of an overview of what JAK inhibitors are and the mechanism of action with respect to treating atopic dermatitis?
Yeah, Chris, you're the real expert in this, but let me kind of give it to you in a dumbed down version for a simple dermatologist like myself. So we know that there's over 50 different cytokines that actually signal through the JAK-STAT pathway. And for us in dermatology, there's a couple key cytokines that are driving the diseases that we are interested in. And for atopic dermatitis, there's what we call these type 2 cytokines, such as IL-4, 13, 31, just to name a few. And it turns out that there's 4 pairs or 4 members of the JAK family that exist in pairs. And depending on the pairs, they will determine which cytokines they will signal. So the trick is that you got to find out which pair of JAK proteins signal the cytokines that you want to block. And it's nice to know that for atopic dermatitis, it really is this JAK1 member. They seem to be the predominant JAK isoform that signals through these cytokines. And very simply put, JAK proteins are intracellular. They're actually going to be inside the cell. And once the cytokine binds to the receptor through a series of what is often described as a relay race, there's going to be a series of steps that ultimately leads to gene transcription, and this can produce more of these pro-inflammatory cytokines. And so while we have historically blocked the signaling cascade by using monoclonal antibodies that could target a cytokine directly or a receptor, now we are able to intervene intracellularly. And by that, we are blocking the JAK proteins, particularly JAK1, for the very reason that we talked about.
Yeah, I think that's a really good way to think about it. I've always liked simplifying it to, we have our antibody-based drugs that are targeting either cytokines or receptors outside the cell. And what makes JAK inhibitors so special is their ability to function inside the cell, right at that endpoint of the signaling machinery as it's trying to impact gene transcription. And I think you touched on something very important, a concept of the molecular heterogeneity of atopic dermatitis. You mentioned IL-4, IL-13, IL-31. Certainly there's IL-22 as well as interferon gamma that can play a role in atopic dermatitis. And this heterogeneity, I think, really speaks to, one, the differences in the clinical phenotypes that we see among atopic dermatitis, but it really gets to the core of what we're talking about today in efficacy. Why is it that the JAK inhibitors are proving so efficacious in atopic dermatitis? They're able to block more cytokine signaling at once because of their ability to inhibit multiple different cytokines. They're able to have a more broad inhibition of the inflammatory pathways which are involved in atopic dermatitis. So with that background about the mechanism of JAK inhibitors and how they're tailored, their ability to hit multiple cytokines is tailored to treating the heterogeneity of atopic dermatitis, Well, let's talk about some of that efficacy in the clinic. So first, why don't we start with short-term efficacy? And I think by short-term, I think we mean on the order of like 16 to 24 weeks. What evidence is there for the short-term efficacy of JAK inhibitors in treating atopic dermatitis?
I think the hallmark feature for this entire JAK inhibitor class, whether you looked at it as monotherapy or corticosteroids, and you looked at it just against a placebo or inactive comparator, the thing that really stands out is the speed. I mean, how quickly this medication works. We're almost talking like spontaneous improvement or like instantaneous improvement, excuse me. And we've seen this not just with the skin clearance. We're talking, even in matter of a weeks, 2 weeks, sometimes people are getting at least a 75% improvement. But the itch reduction, that's probably been what's been the most pronounced, I would say, effect of JAK inhibition is that within hours to days, our patients are reporting having a significant reduction in their itch. And I think with the JAK inhibitors, what they are now allowing us to kind of reach for is not just a 4-grade reduction in itch, which has been historically what the FDA would consider to be a meaningful itch, but it's really getting to an itch-free state. I mean, you have literally no itch or very trace itch. And I think that is a new endpoint that we are now seeing that is being consistently achieved by our JAK inhibitors. And we're doing this very, very quickly.
Yeah, I agree. We're going to come back to that concept of combined measures of EZ90 and the itch NRS scale of 0 or 1, hitting that no 0 itch or only like 1 on that scale. So we're going to come back to that in a little later, because for all our listeners out there, we have breaking news today. We have Level Up trial data that broke today, and we're going to touch on it later in our podcast. So stay tuned. One of the things that I think is really important about short-term efficacy. So when I look at network meta-analyses, and we're going to come back to that topic also a little bit later, but the idea is to compare week 12 to week 16 studies, looking at not just JAK inhibitors, but also comparing them to the biologics. This is an indirect way, right, to compare medicines when you can't compare them head-to-head in head-to-head in clinical trials. And I think that what's really important to understand is in the short-term efficacy, when you're looking at EZ90 responses, kind of this new bar that you were speaking of, James, this new bar of EZ90 to go with that itch NRS of 0.1. What we see is that at week 16, that we're seeing that what I like to call the gold, the silver, and the bronze, the first, second, and third place in these analyses are all JAK inhibitors, right? In the latest network meta-analysis that Dr. Jonathan Silverberg presented, showed upadacitinib 30 milligrams at the top, abrocitinib 200 milligrams, and then upadacitinib 15 milligrams. And this is showing that within 12 to 16 weeks, these patients on the order of roughly 40 to 60% of patients are achieving EZ90 relatively quickly. And I think a key point you made is that the itch, I've had patients in my clinic talk about itch gone in 24 hours. Have you seen that in your own patients?
Oh, absolutely. I mean, they said within hours of taking the pill, they started to know that this was going to work. And I would say that's pretty consistent amongst my patients.
Yeah. I think that one other thing to point out about just there are differences between the various JAK inhibitors. And I'd like to point out a couple things and get your take on that. So first thing I'd like to point out is when you look at the package label, upadacitinib has no active metabolites. Whereas when you look at abrocitinib, it says it has 2 active metabolites. And so I think that right there, the metabolic pathways that these drugs are undergoing, it's a different metabolism, and there's different active metabolites. And do those parameters affect anything, whether it's clinical efficacy or even clinical safety? But when you look at the network meta-analyses, baricitinib, we don't talk a lot about baricitinib in the United States for atopic dermatitis. We're focused on alopecia areata, but in Europe, they are using baricitinib for atopic dermatitis. But the baricitinib doesn't seem to work as well, and then at least based on the network meta-analysis comparison. Are you able to touch on that at all?
Yeah, great points. And like you said, baricitinib has been studied for atopic dermatitis, but was never approved in the US as ex-US. And the numbers just simply don't look quite as good as what we've seen with either upadacitinib or abrocitinib. And that network meta-analyses that you mentioned, Chris, really kind of supports that. And just anecdotally, we've had patients that had both atopic dermatitis and alopecia areata, and maybe they were doing well with one particular agent for their AD, and then I put them on baricitinib for their alopecia areata, and then their atopic dermatitis flared. And so we kind of had to pick, which drug are we going to really kind of prioritize? And I think that just speaks to the fact that, yeah, not all of our JAK inhibitors are the same. They have different selectivity. Some are more selective for one particular type of JAK protein. This term pan-JAK that's being thrown around with like tofacitinib, for example, is much less discriminatory than some of our, I guess, our second generation JAK inhibitors, right? Like upadacitinib or abrocitinib, which are far more selective for JAK1. And half-life, I think, are different, tissue distribution. But you kind of hit on it too, the metabolism or the metabolites. I think that may have implications as far as drug-drug interactions, and also as far as how to adjust these medications from a dose perspective based on someone's kidney function. If you were to read the label for these different JAK inhibitors, the dose modification is going to be a little bit different based on the GFR, and that can maybe speak to whether or not they have an active metabolite or not.
Yeah, I think you raised really good point about the selectivity of the JAKs. And, we kind of think, or we talk about them from a clinical perspective as, oh, it's a JAK1 or JAK2, or it's a JAK3 or a TYK2, or it's a pan-JAK, right? We throw around that language in describing the medicines, but it's not so simple, right? Because you can have a JAK1/2 inhibitor, you can have two JAK1/2 inhibitors, but one be much more selective for JAK2, but still hit a little bit JAK1, and then the opposite for the other drug. So you actually have to know the binding affinities to each of these JAK family members, because it matters. It's not just, yes, it may hit it, but is it hitting it strongly or weakly? And that variability actually does matter clinically. And I think that's what we're learning, not just from AD, but when you bring in alopecia areata and some of these other diseases where JAK inhibitors are now being used, you're starting to see the variability and where selectivity matters.
Absolutely. Absolutely.
So with that being said about the short-term efficacy, well, what about long-term efficacy? What data do we have that, okay, let's say that we have a patient that's achieved EASI-90 and itch in RS001, this new standard of care in atopic dermatitis. They've achieved that at week 16.
Yeah.
What happens beyond that? What data do we have?
Yeah, we have, really, I'd say, promising long-term extension studies, both from upadacitinib and abrocitinib, is that if you were able to achieve a certain level of a deep response, whether that's EASI-90 or NRS 001, and you were to follow these patients out up to, I think, 3 years now with upadacitinib and 2 years with abrocitinib, we're seeing very, very consistent and durable results. We're seeing nice flat lines. And in these patients, you weren't actually allowed to go up and down the dose, at least for these studies. You had to stay at the same continuous dose. And they weren't allowed to use any really rescue medications as well. If they did, then those patients were considered to be failures. So by and large, we're looking at patients who are treating themselves with monotherapy, and we're seeing very encouraging results. If you're doing well at that 16-week endpoint, very good chance that you are going to continue to do well over the long term.
Yeah, I think that is exactly what the data is showing, is that how you respond at week 16, how you respond at week 32, how you respond at week 48, I think you're seeing, at least in the case of upadacitinib and abrocitinib, you're seeing on the order of easy 90 results around 70% at about a year, and 45% or greater at EASI 100 at a year, at least in one study published in the American Journal of Clinical Dermatology. And so I think that the take-home point is that there is this sustainability of the response. And I will say that sustainability, whether it's the clinical skin response, the eczema skin response, or the itch response, it actually depends on the patient's remaining compliant taking their medicines. And for me, in my own clinic, I haven't had as many of the side effect issues. It's more of the patient compliance. These medicines are working so great, their skin gets clear. They're like, oh, I don't need to take my pill. And then things come back. Oh, and I do need to take my pill. How have you addressed or witnessed patient compliance with JAK inhibitors in your practice?
It's actually been very similar, Chris, from a safety standpoint. And never trying to minimize safety, but it really has not come up all too often for me. And to your point about the efficacy, yeah, these patients feel so good, they just forget they need to continue to taking their medications. And some actually do okay off their medicine for some time, but others, flare fairly quickly. And um, Chris, I'd be interested to hear your take on this. The fact that they're small molecule inhibitors, they work inside a cell. You're not necessarily developing neutralizing antibodies. Do you feel like that may partially explain why we see such good durability with these JAK inhibitors, and why, at least personally, I feel comfortable if a patient were to stop the medication for whatever reason and they had to go back on it, the recapture rate seems to be very, very good with my patients who take JAK inhibitors.
So I do agree with you. I think that there are mechanisms by which antibodies lose their effectiveness, as you touched on. And I think the small molecule drugs like the JAK inhibitors, they have their own issues, but I think we're seeing in atopic dermatitis this great, as you said, recapture rate, this is sustainability. One of the things that does happen is, right, the CYPs can be upregulated. Patients can have changes in transcription or upregulation of certain CYPs. And so you got to watch for metabolism when it comes to small molecule drugs and changes in rates of metabolism. And I think you had mentioned organ function, particularly the kidney earlier, but certainly liver function can play a huge role in that as well. So the overall comorbidities of a patient. But by and large, I think that what we're seeing is a very strong sustained long-term efficacy. So if you have this if you see it in the short term, we're really seeing it in the long term. And as you noted, it's for both the skin and the itch. And I think that that's where the patients are getting the greatest amount of leverage from the JAK inhibitors. And I point out, I don't know if you've seen this, I presume you have, that there's data from the Target Derm registry showing that if you achieve an itch of 2 or 3, that your quality of life is 30 to 40% worse than if you're able to get an itch of 0 or 1. And I think that this is where that concept of really having to hit itch NRS 0 or 1 and your easy score target is so important, because the quality of life is dramatically dropped by just going from an itch score of a 2 to 1. Could you have imagined that that would be such a dramatic change in quality of life?
No, that's such a good point. I mean, I think for a long time we were, giving ourselves a pat on the back if we got someone to easy 75 or like a 4-grade reduction in itch. But like you just mentioned, I mean, just that difference from going from an NRS of 2, which is still pretty good, right? That's just mild itch, to an NRS of 0, 1. It's a profound difference. And we saw the same with easy 75 and easy 90. I mean, it seems like there's not that much of a difference there. But from a patient's perspective, we're talking maybe a 3 to 4 times likelihood of getting to an ideal state when it comes to quality of life. And when you add both of those on, right, easy 90 and NRS 01, even better. So I think that's just really teaching us that we need to be not settling just for good. We really should be trying to do what's best for our patients.
Yeah, I agree 100%. So let's switch gears. We've talked about the efficacy and highlighted some of these key things about the JAK inhibitors in atopic dermatitis. What about the safety profile? So let's talk about the short-term safety events. Well, what do you see most commonly in your practice, James?
Yeah, so I think for the first 16 weeks, or the placebo control period of any study, you're going to see the more common adverse events. And I think that's helpful for that regard, whereas the rarer ones will take a longer amount of time for them to actually show up. For me, just in my practice, maybe a little more nausea, maybe some headache, maybe some acne. I'd say maybe those are the ones that I see. Lab abnormalities, honestly, it has not been all that much. I mean, I might see a little blip in the cholesterol levels, but it's interesting. The LDL goes up a bit, but so does the HDL. So it kind of goes up in lockstep with each other. And beyond that, shingles, I would say I've rarely seen it. I could probably count on one hand how many shingles cases I've seen, but certainly this is something that we see with just a JAK class in general. And none of my patients who got shingles actually were vaccinated. So I'd say those are probably the main ones, Chris. A little nausea, a little acne, maybe a little headache, and some inconsequential lab changes for me, at least.
Yeah, I think there's a few really good pearls that you mentioned in there, and I'll touch on first the headache. I think the headache is something that if you look across a lot of the trials, not just in atopic dermatitis, but areata, that this signal of 5 to 7% of headache among these JAK inhibitors, somewhere in that ballpark, is there. In my own practice, the acne, I'll be as someone who actually studies and researches acne, I'm very disappointed because I'm not seeing the JAK inhibitor-induced acne in my patients. Not sure. I'm sure it's coming at some point, but I just don't see it very often. And so I do think that the rate is low, and certainly some of the studies, it's on the ballpark of where the headache is, and then nasopharyngitis, upper respiratory infections. But by and large, very safe medicine, certainly in the short term. So James, I really like the point you brought up about herpes zoster. Herpes zoster was actually the most common adverse event seen in the long-term safety evaluation of upadacitinib in AD, at which is now at up to 5 years, at around somewhere between 3.1 and 5.5 events per 100 patient years, depending on the upadacitinib 15 or 30 milligram dose. But the key point that I wanted to bring up was that less than 5% of patients in this particular trial had the shingles vaccine. And I do recommend shingles vaccine for all my JAK inhibitor patients that are meeting the CDC age recommendation of around 50, or those that might be immunocompromised. But I think this particular adverse event, certainly the numbers can be much lower if patients are vaccinated. And I think that is an important point that you bring up. In terms of the long-term safety of JAK inhibitors, what do you think about some of the adverse events of serious interest that have really captured a lot of the dialogue in dermatology the last couple of years? I feel like there's been a lot of noise, but very little bite. Do you agree with that sentiment?
100%. I mean, can these things happen? Sure, they can happen. The incidence rates are very, very low, but they can happen. We're talking in the order of 1 out of 1,000 patient years, maybe. And Chris, you're the expert in this, amongst many other things, but when you look at the real world population, or you compare it to other studies, we're talking an incidence rate that's very much consistent with what we see in the background rates as well. So, when I talk with patients from a counseling perspective, I'm like, yeah, it can happen on this medication. It's rare. People generally have risk factors, and it's hard to say whether it was really due to the medicine or the fact that you've already had a blood clot before and you have every other risk factor before. Or is it really the medication? We don't know that, but what I can say is from my personal experience and from my review of the literature, we're seeing rates that have been very, very low. Again, very much consistent with what we've seen with a lot of other kind of studies showing what the background rate is for these diseases.
Yeah, I think you raise a good point that causality versus association is a very difficult thing to distinguish in a lot of these adverse event data capture from clinical trials or even real world clinical experience. It's a very difficult thing. I like that you brought up the background rates of adverse events. Something that I've talked about and certainly lectured on is that if you're going to try to understand an adverse event, you actually have to know 3 things. You have to know the baseline rate of that event in the healthy population. Then you have to know the rate of that event in your disease state population without treatment. And then you need to know the event rate for that disease with the treatment of interest that you're studying, right? If you don't know those 3 things, you can't properly place an event rate on a medication in its proper context.
Yeah, and then you bring up such a good point about just disease-specific incidence rate. Talking rheumatoid arthritis patients and inflammatory bowel disease patients who are also being treated with JAK inhibitors. And when you look at their event rates, it looks a lot different than what we see with our population as well. So I think it's important that we have disease-specific incidence rates as well, which is why you bring up that really good point about we need to have much more of a nuanced approach when we're just looking at incidence rates, right? We have to break it down by the disease state.
Yeah, absolutely. And I think that this is really important. I think, for example, I'll bring up, the just MACE rates. You look at using a Danish population that looked at moderate to severe AD, the MACE incident rate was around 0.63 events per 100 patient years. And so for people that are listening that don't know MACE, major adverse cardiovascular events, such as like heart attack, stroke, that rate in the moderate to severe AD population of 0.63, when you get to abrocitinib or upadacitinib, those rates are generally on the order of 0.1 or 0.2, depending on the data cut as we get out further. But the rates seem to actually be going down, and I think that this is a great example where, yes, if you see adverse events in a clinical trial, or if you see a medicine may have a boxed warning for that event, whether it's cancer, clotting, or cardiovascular risk. The point is that when you look at these background rates, at least in the case of the JAK inhibitors for atopic dermatitis, I actually think a lot of bark and little bite is how I would describe it.
Yeah, and for the listeners that may not be as familiar with what the patient demographics look like for these studies, whether it's with upadacitinib or abrocitinib, I mean, these weren't necessarily your 18-year-old Olympians, right, that had no risk factors. I mean, many of these patients had risk factors that we would consider to be maybe more risky. Over half the patients had at least a cardiovascular risk factor. Just under a third were current or former smokers. About 1 in 5 were on a combined oral contraceptive. And so I think the safety data, some people may say at first blush, you're kind of cherry picking a healthier, less risky population, but I would disagree with that. I would say that based on the data that we have from upadacitinib in particular, this is very reflective of what we're seeing in the clinics. And so I think this data does help us with that as well.
I agree. So I'd like to move on to looking at comparative studies and real world evidence. So head-to-head studies. Let's just go ahead and start with the breaking news today. So what we had today was Level Up data. Level Up was an open label efficacy assessor blinded head-to-head phase 3b/4 study that was looking at the efficacy and safety of upadacitinib starting at the 15 milligram once daily dosing, starting dose. And this could be dose adjusted upwards to the 30 milligrams based on clinical response. So upadacitinib was being compared to dupilumab per its labeled dose regimen. And this was in adolescents and adults greater than or equal to 12 years of age with moderate to severe atopic dermatitis. And I think that, James, what's so significant about this is that this is actually the first head-to-head trial in atopic dermatitis that's assessing upadacitinib at the starting dose of 15 milligrams versus dupilumab at the labeled dose. So we have another study where they actually looked at the 30 milligram dose compared to dupilumab in the Heads Up trial, but we're going to focus on Level Up and really understand this because, James, you mentioned about this combined efficacy, looking at EASI-90 and itch NRS 0 or 1, and that was the primary endpoint for Level Up. And the data showed at week 16, basically 20% response for upadacitinib and 9% response for dupilumab. So almost twofold, great, more than twice as many patients achieve this combined EASI-90 and itch 0 or 1 composite endpoint. What does that tell you? What's that data mean to you as a clinician?
Yeah, at first blush, you might be like, it's still only 20%, but that is so difficult to achieve, right? We're talking about this deep level of skin clearance, a deep level of itch reduction. And as we kind of alluded to at the very beginning, like on paper, it may not seem like that much of a difference between EASI-75, EASI-90, or NRS 0 or 1, and NRS 2 and above, but it's very significant difference. And if we want to give our patients the best chance of having a life that is not affected at all by atopic dermatitis, we need to be able to achieve both of those endpoints simultaneously. And the fact that we can do that at about twice the rate that we're seeing what many consider to be kind of their first kind of go-to systemic agent for atopic dermatitis, which is dupilumab, I would say that really just gives us additional data that, hey, if we want to get our patients better fast, which I think really matters for atopic dermatitis, and I think the area under the curve here is going to be important too, is just how long can you keep people in this level of disease clearance for the longest amount of time. I think that's going to really help guide our treatment decisions as well.
So I'd like to point out that the secondary endpoints were, if you break it apart, the EASI-90, upadacitinib showed superiority to dupilumab for just looking at EASI-90 at week 16, basically 41% to 22.5%. And then it also showed superiority for just the itch NRS of 0 or 1, weekly pruritus NRS of 0 or 1 at week 16, basically 30 compared to 15.5%. So again, almost that double figure. Mm-hmm. So when you look at the secondary endpoints, just EASI-90, basically 41% with the JAK inhibitor achieving EASI-90 and 30% achieving this itch 0-1. How does that sound to you?
Yeah, I mean, it sounds wonderful. I mean, again, we have dupilumab. It's a great medication. Don't get me wrong, but the fact that now we are able to get twice that level, twice the likelihood of achieving these responses, I think, is very, very encouraging for our patients. And one of the things that we've seen with atopic dermatitis is that sometimes there could be a discrepancy between what the clinician is seeing, like an EASI score, and what a patient is feeling. So there's this kind of patient-physician discordance, which is why having these combined endpoints where you have a clinician-reported outcome, like an EASI score, and a patient-reported outcome, like an itch score, that I think is going to give us a much fuller picture of how this patient is doing as well.
So I think that it was really fortuitous that Level Up came out today as we're doing this podcast, because it allows us to really bring breaking news to our listeners about this Level Up trial. It's actually pretty profound data with this composite endpoint comparing a JAK inhibitor to the standard of care biologic that's been out for several years, really showing how innovation in the JAK inhibitor world has actually really pushed forward the standard of care of atopic dermatitis farther than what we thought. But in the Heads Up trial, where they used 30 milligrams upadacitinib compared to the dupilumab per label use, something we don't have from the press release on Level Up and the top line data, we don't have the figures of the curves, right? But what we do have from Heads Up is that when this was a 24-week trial of upadacitinib 30 milligrams once daily compared to dupilumab after loading dose of 300 milligrams Q2 weeks in adults. And when you look at the EASI-75, this was measured through 24 weeks. James, one of the things that was so critical about this data was the rapid rise in EASI-75 response on the UPA and the rapid drop in itch in the similar itch NRS data. What do you make of that? And are you excited to see whether this rapid rise in EASI response and drop in itch response, are you excited to see that maybe Level Up will show that same sharp early on, while we're talking in the first week or two, massive difference between the JAK inhibitors and the biologics?
Yeah, based on what I've seen in my own clinical practice and in the clinical studies we've been a part of, I would not be surprised if the 15 milligram dose is going to get to a comparable type of result as we've seen with the 30 milligram dose. I mean, there's no question there's a dose response with most JAK inhibitors, but I have been very, very pleasantly surprised with even just a 15 milligram dose of upadacitinib working extremely fast, high levels of response. And one of the nice things from the Heads Up study that I think is worth mentioning is even after that 4-week endpoint, people got switched then to who were on dupilumab, they got switched to upadacitinib 30 milligrams, and we got to see just a bump of itch response as well as skin clearance from making that switch as well. So I think that kind of just helps us understand that even people who are doing pretty well, there's potential they could do even better. And so we should probably be asking our patients, every visit, not just, how are things, but really what's the impact that your AD has on your quality of life. And even if it's, even if it's not that significant, at least they still deserve to have a conversation that we can maybe get you even better by switching you to another medicine.
Absolutely. And just to round out our discussion of head-to-head trials, I just mentioned the JDARE trial where abrocitinib at its 200 milligram daily dosing was compared to dupilumab per label dosing for 26 weeks. And we really saw a very similar thing where very early on in the first 4 weeks, this distinguishing both an EASI response, here is EASI-90 response through week 26 of around 30% at week 4, right? 30% at week 4 compared to 15 between the abrocitinib 200 and the Dupi. And so this rapid early distinguishing between the JAK inhibitors, both abrocitinib and the upadacitinib, has been seen for both the EASI and the itch measures. And I think that for me, I can't wait to see what the Level Up figures look like, the curves look like, because I think that this trend of early rapid response, the short-term or very quick early onset response captured in the level up. I suspect it is, but we don't know. And I think the abrocitinib JDARE trial and the upadacitinib heads up trial certainly have paved the way for what's been achieved in level up. Because in a way, when you think of the JDARE trial and the heads up trial, really now we're combining, right? They looked at EASI, either 75 or 90 response or itch response, and now we're combining it all together and saying, how well does the JAK meet this composite endpoint measure? And I think that is, again, one of the key take-home points to dermatologists in general, is that the standard of care of atopic dermatitis has changed. It's EASI 90 plus itch 0 or 1, itch NRS 0 or 1.
Yeah, one of the things that we learned from those head-to-head studies is that when you look at less stringent endpoints, it's harder to see separation. So like an EASI 75, we saw that dupilumab actually did quite well. And even though it took longer to get there, it got to a comparable rate than whether abro or upadacitinib. But when you looked at the more stringent endpoints, like we should be reaching for, EASI 90, EASI 100, NRS 01, that is, you still saw that healthy delta between the JAK inhibitor and dupilumab. And so I think, and this is true for a lot of diseases, when you just look at more and more stringent endpoints, that's when you can start to separate the drugs out even better. And I think that these head-to-head studies really prove that.
I think that's an excellent point. The more stringent endpoints actually really start to distinguish the medicines more than the less stringent endpoints. And that's a very good point. So speaking of studies in general, we touched early on, I brought into the concept of the network meta-analyses. So the bottom line is we still have very limited head-to-head studies, only for a few medicines, certainly not even with all the biologics in atopic dermatitis, and with 2 of the JAK inhibitors, right? That's what we've got. That's all we've got. And so the question is, why do network meta-analyses, and how reliable are they? Can we trust them to be good indirect measures of comparing medications so that we can make clinical decisions based on them?
Yeah, it's a good question. And I think, head-to-head studies are hard to do, especially against 2 drugs that are very similar in the same class, because it's probably a lot of money that you're going to spend, and you're probably not going to show what you want to show. So I think there's a reason that you rarely see these type of head-to-head studies. So I think network meta-analyses are our next best option to have these comparisons across studies that had maybe slightly different patient populations, different investigators, different sites, and have a systematic way of controlling for some of these variables to make it maybe more of an apples to apples comparison when it really is not. Of course, network meta-analyses also have some limitations, and sometimes depending on how you do it, you can make your drug, depending on who's sponsoring the network meta-analyses, look more favorable than another drug. But I think they are useful, Chris. But I think it doesn't answer the question as to, if you have a patient that's doing not so great on one drug, and then you switch them to another drug, how will that patient do? And I think that is also very, very helpful, because right now we're just looking at head-to-head data. If they were not on any medicine before and you just had your first crack at them, which medicine is going to work the best, versus you're on one medicine, you're not doing well, let's switch you to another one. And I think that's another set of data points that we're going to need.
Yeah, I think that's a very good point, is that as more research is done in atopic dermatitis, we see in the psoriasis world, right, biologic experienced, biologic naive. Okay, well, now you can break down that to classes, whether it's your TNF alpha, IL-23, IL-17, right? You can break that down and say, okay, are you biologic experienced in all of these or any of these classes? And so eventually we are going to get to that point in atopic dermatitis where we're able to say, well, are you upadacitinib experienced, or abrocitinib experienced, or dupilumab experienced, or tralokinumab experienced, and even lebrikizumab experienced? So all of that's going to come into play down the road, plus all of the innovation that we haven't even talked about, and it's beyond the scope of this particular podcast. So I just wanted to bring in now the concept of real world evidence. What does that mean to you? When people are throwing around this word real world evidence a lot now, what does that mean to you? And what can we tell our listeners about it?
Yeah, I think very simply put, we know from experience that how a patient does in a randomized controlled trial isn't always reflective of what we see in the real world, where things aren't so controlled. And that's true for an efficacy standpoint, where the drug just may not work quite as well as we saw in the clinical trials, but also from a safety standpoint, right? You might see things pop up in kind of later real world studies that weren't detected in a randomized controlled trial. And so what we want to see as clinicians is, can what we see in the real world, will that mirror what we've seen in the randomized control trials? And I would say that from an efficacy standpoint, honestly, it's been as good as advertised. I mean, we're seeing incredibly high levels of efficacy in patients who are bio-naive, multiple biologic experienced. But also, I think from a safety standpoint, this real world data has been even more helpful, because honestly, we talked about this at the beginning. I am not seeing these things come up all that often, and the ones that do come up, we could usually work through them, fairly easily as well. And at least to my knowledge, probably the largest real world kind of data that we have is coming from the Corvitas registry, where we have several hundred patients that are on JAK inhibitors. Many of them actually are bio-naive, so it's interesting that now we have some of our colleagues that feel comfortable going straight to a JAK inhibitor versus having to step through maybe some of the other traditional medications. And from an efficacy and safety standpoint, I think it really has kind of corroborated what we've seen in the RCTs.
Yeah, I really like and agree with everything you said there. That in particular, you said that the efficacy was as advertised. I would say that the real world safety is better than advertised, and I think you're dead on there. So James, thinking ahead to the future, are there any developments in the field of JAK inhibitors for atopic dermatitis, or upcoming research or trials that you're aware of that you're interested in?
Yeah, Chris, I was going to mention the Level Up study, because that's something that we've all been looking forward to, for the first time having the on-label dose of upadacitinib versus dupilumab. But I think, to our pleasant surprise, the top line data at least came out today. So I think I am going to be looking more for the longer term data, and maybe just to get a little bit more kind of a granularity to what these patients look like, who were the super responders, who required dose escalation on upadacitinib. But that's probably the one study that I am looking forward to most.
So with that said, we talked a lot about how JAK inhibitors address the heterogeneity of atopic dermatitis, and I think that's key to how JAK inhibitors fit into the broader landscape of atopic dermatitis in terms of therapy. We've seen with the AAD guidelines for atopic dermatitis this strong recommendation, right, for JAK inhibitors. I think that is key, and we've also seen a down recommendation for traditional immunosuppressants, as well as a conditional or a recommendation against corticosteroids, systemic corticosteroids. So I think these guidelines themselves, that the landscape has already shifted, because we're seeing this strong recommendation for JAK inhibitors. And I think that some of the stuff you touched on almost makes me think, well, are JAK inhibitors really first-line therapy in atopic dermatitis? Do you think that we're going to get to that point?
Absolutely. I think, of course, it's always personalized medicine. We want to make sure that this is a shared decision-making process, but there are certainly patients that prefer the flexibility of taking a pill. They want that very quick onset. And, we can argue a lot about how important is speed for other diseases, but for atopic dermatitis, it is one of the most important attributes, is how fast a drug works. And so, I've had a number of patients that wanted the fastest working drug because they were so miserable, right? So that patient certainly could go straight onto upadacitinib, as long as they've been on a systemic agent before. But I think this concept that you have to go through maybe a biologic before you get onto a JAK inhibitor, we're going to see that changing, I think, in the future. And I think, based on the AAD guidelines, like you just recommended, it's on parity now with the biologics as well. So certainly, I'm looking forward to our colleagues using this drug more and more. And yes, I can see it becoming a first-line agent for many of our patients as well.
Yeah, I think with so many patients, I think some of the data shows anywhere from 50 to 75% of patients have already had systemic corticosteroids anyway, right? So there is a lot of dermatologists are going straight to the JAK inhibitors. And so I just wanted to summarize, what we've talked about today really is focusing in on the efficacy of JAK inhibitors in atopic dermatitis. I think we hit a couple key points. Number one, that the standard of care is now a combined measure, hitting EASI 90 plus and itch NRS of 0 or 1. It's not or, it's both, hit both at the same time. We touched and highlighted on head-to-head trials comparing JAK inhibitors with dupilumab, whether it was the JDARE trial, the Heads Up trial, or breaking today news about the Level Up trial. We shared some of the data that was put out in the press release. Certainly, we don't have all of that data, and we certainly want to analyze that more. But I think the key takeaway here is that we have excellent skin clearance, we have excellent itch reduction, and it can happen fast, and it can be sustained, and it can be done safely. So, Dr. Song, we've had this great discussion. Do you have any final thoughts that you want our colleagues listening in on to take away about the use of JAK inhibitors in atopic dermatitis?
Chris, you summarized that wonderfully. And maybe just the one thing I would say is, and we've hit on this over and over again, is, you have patients out there that could be doing maybe okay on their biologic. And maybe not every single patient is going to want to switch, but they at least deserve a conversation about all their therapies out there, because we know, based on what we just discussed, that getting a patient to even a higher level of skin clearance and even a better itch reduction will translate to a better quality of life overall. So I hope that our listeners feel comfortable to have these conversations with their patients and just be proactively bringing it up. And like I said, not everyone's going to say yes to it, but I think there's going to be a lot more than they think.
Dr. James Song, thank you so much for being a guest with me on this podcast today. Your insights have been so helpful and wonderful for all our listeners. I encourage all the listeners out there to this Live Derm podcast program on JAK inhibitors for atopic dermatitis to continue to stay informed about the latest developments in atopic dermatitis treatment. You can do that here on the Live Derm podcast. This was our second episode, JAK inhibitors in action, effectiveness in atopic dermatitis. And we have 4 more episodes to go. The next episode, I'll be featuring as a guest, Dr. Jonathan Silverberg, and we're very excited to continue this podcast to help educate about atopic dermatitis and how to incorporate JAK inhibitors into your treatment regimen.
Thanks for the opportunity. Great to be here.
Stay tuned for our next episode in this series, a program on JAK inhibitors for atopic dermatitis, featuring Dr. Naeem Issa and Dr. Ruth Ann Vlegels. Thank you.